This is Father Tom Knoblauch. I serve as the consultant for the Diocese of St. Cloud for healthcare ethics, and I've been involved with St. Francis Health Services for a number of years. I want to commend you on your mission and your part in fulfilling the mission of St. Francis Health Services. Just briefly to recap what that mission is, we are committed to express Christ's message of love and hope by providing for health, residential, community, and allied services in a holistic, competent, and caring manner that recognizes the value and dignity of every human life. That's what I'd like to speak about briefly today. In my experience in pastoral ministry and certainly working with healthcare organizations, one of the issues that often arises is the difficulty in keeping the focus on the person, keeping the human person human. We live in a very high technology society, a very impersonal society in many ways. And offering this service to those that are residents in your facilities becomes a very important mission and ministry as an extension of the outreach of the gospel. I reflected a little bit on some ways in which persons are dehumanized in healthcare, and I want to start with that, not because I think it's all that common, but we know that it does happen. Some experiences from my own ministry and those that have been shared with me. One of the difficulties that we face is viewing care receivers as the problem, kind of an objective problem to be solved. At an ethics committee meeting, we were visiting with a family, and one family member said of their dying family member, "He should have died years ago. I wish he would have." And that opened up a whole set of family dynamics, and the needs of the person, the wishes of that dying person for directing his own care, unfortunately tended to get lost as we tried to work our way through this problem that had emerged. And it's always important to bring the focus back to the person. What does this person need and desire? A second difficulty is viewing sick persons kind of as outcasts. I had this experience with a gentleman, a parishioner of mine some years ago, who was dying of cancer, and he complained as I visited with him, "Where are all my friends? I'm still the same person." People unsure of how to interact with him or what to say tended to avoid him, and he felt very isolated and lonely. To remember that whatever their condition and need, that persons remain who they always were and are in need of personal attention, care, and respect. A third problem that we can sometimes face is that family members or residents can become kind of the lever for individuals to get their way or to sometimes manipulate others. This also came from an ethics committee meeting. It was a woman whom I'll call Clara, who was in a hospital and was in the last stages of her life. Family member came and presented himself as representing the entire family with a care plan and said, "We're all on the same page with this." And as discussions continued, what we found was that, in fact, not everyone was on the same page. There was some very bitter division in the family, but it took investigation and some patience to get to that and work through those family dynamics. We always remember that residents or patients are a part of a whole system of relationships, and care for one means care for that whole system at times. And so we want to avoid an individual being just sort of a chip, a bargaining chip, in a larger set of problems that have to be faced in a family. A fourth problem is a care receiver simply as part of the furniture, not really being attended to, talking about people in their presence as though they weren't there, acting as though they really are unable to participate in their own care when in fact they are. I spoke with one of our parish members who was in a rehab unit and told me later that she heard all about the wild weekend that her aides had, and they were talking about their own personal lives and completely ignoring her, even though they were caring for her bodily needs, but as though she weren't there. That's always a danger that we have to avoid, to be present to the people that we serve. My own mother talks about, she's in a long-term care facility, talks about being treated like my second mom. Certainly we want to be warm and on friendly terms with the people that we serve, but also respectful She sometimes feels a little bit belittled by those who care for her. They act like I'm a child, she says. And certainly the needs of people, particularly with memory loss, change, and we have to accommodate those needs. But at the same time, not to treat them in a childish manner or to minimize their human dignity. A sixth difficulty related to some of the others is just the care receiver as an object, merely almost like a piece of machinery that one is working on. There have been some great articles in the healthcare ethics world. The Other End of the Endoscope was written by a physician who did endoscopies and all of a sudden had to undergo one, and realizing what that was like to simply be operated upon as though one were not even human, not even present there. Another article was entitled, "I Can't Hear You While I'm Listening," a doctor who was listening to a patient's heart rhythm, and she was trying to describe her symptoms and her problems, and this was the comment that he made to her, "I can't hear you while I'm listening." So to always be attentive to the whole person and to interact with them in a truly personal manner. Perhaps the worst case scenario is vulnerability of others that we care for as license. The idea that we can do whatever that we wish to them and they don't have any real recourse. They depend on us. Dependence is a reality, but that becomes a responsibility and not license to do whatever we wish. The worst case scenario, of course, is cases of abuse that happen to vulnerable adults and those with memory loss. We've heard some very tragic cases that have happened even in the state of Minnesota. We don't know how prevalent abuse of elders is. Certainly it doesn't all happen in facilities. It can happen in homes and private homes as well. But one case is too much. So always to be mindful of the dignity of the persons that we serve and the people that we work with as well to provide that care. Truly to care for persons with competence, compassion, and attention humanizes us. It humanizes those we care for, and it humanizes those giving the care. We recognize that the tasks that we do are part of a larger set of a relationship between persons who are in need, persons who provide for their needs. But those who have done well in caring relationships recognize that they also grow, they also benefit from providing the care for others. It helps us to become more aware of our common humanity. And though we may be in a position to serve others, there will come a time in our lives, each of us, when we need that care and respect from those around us, when we become dependent. And those who do best keep that always in mind. Our goal in care is not simply to avoid the worst case scenario, not simply to avoid abuse, but to give the best and most humane care possible to those we serve. That's not easy to keep in mind when budget pressures and time constraints and feeling overwhelmed and perhaps things from our own personal lives or relationships that we've just had with another resident kind of color and cloud that attention that we give to the next person. But we try to create a culture of care for persons in each facility and in each caregiver. It requires constant reminders, so it's not nagging, but we all need that reminder and that occasional refresher. Calls for some vigilance and oversight, but also that personal commitment to do our best each day for each person. The values that we hold create the priorities that guide us, and the priorities that we hold create a whole culture. I've often spoken about this with long-term care facilities in particular. If people watched what happens in our facilities every day, what would they say our mission statement is or our values are? And to draw that contrast sometimes between what we say we do and are and what actually happens. And the purpose of leadership and the purpose of collaboration in a facility is always to bring us back to be the best that we can, to do what we say we do, to be who we say we are. So what is the human person? Well, like everything else in our postmodern culture, there's no agreement on that. And so sometimes we have to just set aside philosophy and theology and law, even though they all have something to say about persons, and go back to our kind of rough and ready understanding. In St. Francis Health Services, as a Catholic network of facilities, we can call upon that rich heritage of our faith and acknowledge that every person is created in the image of God, that we are made in the image of God, who is a communion of persons, Father, Son, and Spirit, as our tradition says, and that our greatness and our dignity come not from what we've accomplished, not from our abilities, not from our social standing, but that we are each a child of God, made in the very image of God. So every person has equal, incomparable, and inviolable dignity that demands unconditional respect. It's hard for us to do that sometimes, particularly when persons seem different than us, differently abled, come from different backgrounds, different cultures, different ages and stages of life. But that is the common ground that holds us together, not only in our culture, but across cultures, recognizing the dignity of each human person. We recognize that people's circumstances change. Their health condition, their relationships, the stage of their life, early, mid, or late, their stage of development or decline. But while all those factors affect how we care for persons, it does not decide whether we care for them. We always must care for them to meet the needs that each person has as best as we can. That's what we mean by holistic care, addressing the needs of the whole person. We recognize that persons are more than just bodies, more than just physical needs for toileting and for being turned and for being fed and nourished, but that we also have needs of the mind, our intellect and our relationships, and spiritual needs. It's possible for us to separate those elements out, to think about them separately in concept, but always to remember that human persons are a unity, a body-soul unity. And what we do to persons in the body affects the whole person. What we do to them spiritually or in relationships can also affect their bodily health and their well-being. We have intersecting needs at all those levels. Certainly everyone has physical needs, our basic life functions, the illnesses and the struggles that we have with our bodies. And as we age, we know that loss and diminishment is a part of that human journey. Psychological needs, our hopes, our fears, our regrets in life, our anxieties and worries, the grief that we might experience from loss. Our social needs, that we have, we're a part of a set of relationships with family of origin, with the community that we live with, the experiences that we've had. Sometimes, for the population that we serve, there are unresolved conflicts, needs for forgiveness, goodbyes that have to be said, memories of departed loved ones that have to be cherished and honored. All those are part of the rich tapestry of life for those we serve. And we have spiritual needs. Everyone has a kind of a basic need for some sense of the transcendent, some sense of meaning and purpose in life. Why am I here? Where am I going? What does my life mean? Where do I fit in the world? Is there a God? And how do I understand God? And St. Francis Health Services has done great work with the spiritual care program, trying to attend in an explicit way to those needs, along with the other needs that are part of the human person. Even if the body no longer functions the way it did in earlier years, even if the mind is no longer in optimal functioning state, the person always remains. Persons can be disabled, persons can be dependent on the care of others, persons can be in need. But those persons are no less human, no less deserving of respect, no less worthy of dignity and attentive care than any other. In fact, it draws a lot out of us because it's easier for us to care for people that can respond and show their gratitude and make us feel like we are persons of worth and value. But reciprocally, that is also true. They need that kind of sense that they are persons of worth and value. And our greatness is measured not in how other people think of us, but how much that we give of ourselves to those in need. Particularly, I want to speak for just a moment about some of the misconceptions that accompany aging and the loss of cognition or memory loss. Sometimes people think that cognitive loss and emotional abilities are directly related, that people who no longer see the world as clearly as they did in earlier times also have a blunted kind of emotional response. That is not true. Their feelings are just as important, and in fact they might become more poignant to them. Our rational life, our ability to think through situations, sometimes helps us temper our emotions. Those with cognitive loss might not have that same ability to sort of put their experiences, their fears, their griefs, their sadness, their hopes in a larger life context. And we have to be aware of that. While cognitive decline affects our rational understanding of the world, the emotional life remains largely intact. Same fears, same anxieties, sometimes depression, anger, shyness, a sense of modesty, simple joys in life, a sense of relief. All of those are often very much present, and in fact perhaps even more intense than we experience. Second, sometimes people think that persons with cognitive loss don't really understand what we do for them, or they don't really appreciate or can't understand how they are cared for. So things like social courtesies, asking permission, saying good morning, being patient with them, being attentive to how they might respond emotionally to what we say or do, sometimes that gets left behind, thinking, well, they'll never know or they won't care, they can't understand. But retained capacities for that emotional life and for understanding the world, maybe in a little slower pace, maybe not as philosophically, but interacting with the world, those retained capacities often remain far longer than people understand or expect. So it's important not to confuse difficulties that residents or patients might have in communicating their needs and preferences with not having them at all. Sometimes it's helpful to limit choice. Sometimes we can overwhelm people by saying, when do you want to get up? What do you want to eat? What do you want to wear? To narrow those choices, give them one or two or three options and allow them to choose. This respects their impaired abilities while still respecting their ability to choose and direct their life in ways that are meaningful and possible for them. A third difficulty in relating to people is either to fall into the two extremes. I know everything about this person, I understand everything about them, or I understand nothing about them. Thinking either that I don't really need to ask permission or ask questions any longer because I know what this person wants, or to think that there's no way to get to what this person wants, and so I'll just do what I decide is in their best interest. It's important to take into account the uniqueness of each person. I know as a pastor having funerals or visiting hospitals or long-term care facilities, I often see people not certainly at their best when their dependence brings them into a particular set of relationships that they would not have chosen, but that they have a whole life history behind them. They've had careers, they've had experiences of joy and sorrow, they've raised families, they've been part of families, they have friendships, they've done some remarkable things. It's not evident or obvious in talking to someone who is in a wheelchair or in a hospital bed, but always to try and respect the uniqueness and the history of each person. Caring means getting to know and getting involved in a real relationship with persons without becoming codependent, without making them dependent on us or us becoming so entwined in their lives that we can't really meet their needs any longer. There was a article some years ago called the Virtual Dementia Tour, and it told of aides, nursing staff, physicians, board members, administrators being given the experience of simulated aging losses. So glasses smeared with Vaseline to simulate vision loss, headphones with static playing to simulate the loss of hearing, gloves with unpopped popcorn to simulate the difficulties of sensation and tactile sensation. And then these folks were given, otherwise very competent and capable folks, were given 5 simple tasks to do. Fold up this piece of paper and put it on the desk. Take out the blue sweater and put it on. Write this one sentence on a piece of paper. And they were so frustrated in not being able to do the simplest things. It was a very, very poignant, powerful experience for many to realize how much they were asking of folks who had impaired abilities, thinking that these were simple tasks, I can do them without even thinking what's taking these people so long or why won't they comply. It's very good to be aware of walking in another's shoes and realizing sometimes what a challenge it is, even things that we think are simple tasks, for those that we care for. It's important for us to name some of those specific human and gospel values that guide us. Everyone deserves respect. Everyone deserves a chance. No one likes to be ignored. No one likes to be ridiculed or put down. And to remember that when we're dealing with the residents and patients that we serve, we are working in their home. They're not living in our workplace. It's a simple, perhaps, difference in perspective, how we view what we do. But it can be very, very helpful to us to remember that they are the focus of our attention. We are not the focus of theirs. All are responsible to care for everyone. Jesus tells us, whatever you do for the least, you do for me. Do unto others as you would have them do unto you. There is no greater love than to lay down one's life for one's friends. And in the words of St. Paul, help bear one another's burdens. In this way you fulfill the law of Christ. Those kinds of principles and reminders are at the core of what we do. And it's good to think about them and to hear them occasionally, to remind us in the midst of our daily tasks and the burden of rendering care, why we're doing what we're doing. The founder of, the patron of St. Francis Health Services, of course, was St. Francis of Assisi. And he tells the story in his autobiography of one of the earliest experiences. He heard the voice of Christ, was converted to the gospel, but says he was not really fully converted until one day he was walking down the road in rural Italy there, in Assisi, and came across a leper coming toward him. And at that time, of course, lepers, as they were in the gospel, were viewed as people to be avoided at all costs. They were feared for fear of getting that disease. And in our day, there are many people who are marginalized and placed on the edges of society for various reasons we fear as well. Francis says that his temptation was to jump in the bushes on the side of the road and at any cost avoid this man. But instead, he ran up to embrace him. And he says at that moment his conversion truly took place, when he recognized Christ in the person of this other. Jesus tells us, once you know all these things, blessed will you be if you put them into practice. We support one another. We ask for the help that we need from God and from one another, to always remember the dignity of each person that we serve.